So I'm talking to you today about increasing nursing time spent with patients. We often perceive this to be the holy grail. I'm talking to you about a mixed methods research evaluation that we did in a live hospital environment in Canberra of a digital bedside nursing chart. I'd like to start by acknowledging the traditional owners of the land, which in Canberra are the Ngunnawal people, but any elders past, present and future who might be in the audience, and obviously the team that we've worked with there. And broadly down to Deakin University as well, we had some support and who had done some of the initial trials on this particular product. So just to give you a bit of an orientation, and I will be moving quickly, I've got about a couple of slides a minute, so I hope you're okay to just keep up with me and take what you need from it, and happy to take questions as we go if that's helpful to clarify any of the topics. Give you a bit of background, talk about the study and talk about some of those implications and recommendations. So we've got an efficiency opportunity, and I guess this is my link here, is that no matter how great our genomics research and development might get, I can assure you that people will still get sick and die, and those people will probably be in hospital and probably need nurses. We've got a large proportion of an ageing population, and they take up a high proportion of bed days. We know that nurses take up a large amount of those costs for maintaining hospitals, and that hospitals take up most of the costs of our healthcare system. So we've really got this opportunity to maximise the use of secondary data, analysing particularly for the care delivery that's occurring and the decision making that's going on in hospital. But for example, and you know, we were talking about different kinds of data sets at the moment, and I'm sure that people are in different health services with different kinds of access, but if we take, for example, ICD-10 coding for patients in hospital when they're discharged, that we can know up to 55 different comorbidities for every patient. We know their length of stay, what procedures they've had during admission. But we don't know out of those 55 different diagnoses, medical diagnoses, whether they are self-caring and independent or bedbound and requiring full nursing care. Neither do we know what staff do for how long, let alone whether it was effective or not. So what we've done in Canberra, what we've done overall in terms of e-health, there's all sorts of different ways of investigating. I'm sure many of you have used some of them, whether it's implementation science or translational research or theoretical domains framework. We've got different names, different methods trying to examine what is effective. But we still know that the clinical decision support systems have had mixed uptake across Australia in particular, and has not been as effective as perhaps hoped or sold. And this is just the most recent example that I'm sure you've seen, where a patient has died over in Western Australia who was at home, but he had had medical tests in the hospital and no staff had actually checked the results of any of those tests that could have prevented that death. They were on a computer somewhere. So for our older patients, we know that a lot of them have more than 5 comorbidities. They have about 10% in hospital have dementia, and up to 30% of people in hospital have cognitive impairment. 90% of people in hospital need assistance with their activities of daily living. That's partly usually why they're in hospital. But we also have enormous functional variability between being fit and old and sick and old. There are a lot of older people, 90 plus, 100 plus, who can still wash their toes in the shower, as well as multiple 50-year-old patients who are needing full care for multiple reasons. Hospitals are increasingly complex places. In the last 30 years, as well as having these increasing ageing populations that are spending more days in bed, we've got decreased acute beds per population. We have bed occupancy over 90%, even though about 85% is considered to be safe. Length of stay has decreased, partly because of our productivity measures focusing on that kind of thing. But that means that we've got increased churn. So while patients are in hospital, they are moving through more places at a faster pace. Simple surgery tends to go to private or day surgery, leaving the most complex cases to be managed by the public system. And we've got lack of senior staff 75% of the week because they're there Monday to Friday, 9 to 5. We've got increased casualisation, along with the rest of the workforce everywhere, and a dilution of experienced nurses, perhaps going into academia or management or nurse informatics, as well as into different sectors. So nursing work in hospitals has changed too over the last 30 years. They are understood to complete on average 72 tasks per hour. Their mean task length is 55 seconds, and duration of a large proportion of their work is less than 10 seconds. They're considering a different patient every 6 minutes, and they're multitasking in this particular study a third of the time. They're interrupted every 6 minutes by colleagues and patients, but every hour by work system failures like medication orders. And nurses are reporting, 55 to 98% of nurses are reporting leaving at least one task undone on their last shift. And there's increasing evidence about, well, does this matter, about leaving tasks undone? Does it matter if we need nurses by the bedside? Do we really need to release this time to care? But each 10% decrease in proportion of nurses is associated with a 12% increased risk of death. and increasingly across the world, the association between registered nurses, staffing, skill mix and patient outcomes is becoming increasingly less able to be ignored. This is the most recent one by Jane Ball in the United Kingdom, looking at missed care in UK hospitals. And part of this comes out of some of the focus on whether nurses are just too posh to wash and don't have time to care. And this is where nurses are actually advocating or articulating what care they are missing. And this shows you that the more patients that a nurse has, the more care that she is likely to ration or miss. Perhaps unsurprisingly, but now at least it has been collected. And you can see that the things that they are more likely to have to ration is the comforting and talking with patients, educating, developing care plans and pathway, patient surveillance, and then down to treatments and procedures and pain management are less likely to be rationed. Makes sense. The more life-threatening things are less likely to be ignored or put off, whereas the things that do not threaten life so much are less likely to be missed. And so where do electronic health records come into this? Well, there's a hope and a promise that they can be consumer and care directed. They can offer potentially shared access to information. Continuity of care and through transitions is potential, possible. There's communication, perhaps aiding through multidisciplinary and transboundary pathways. The argument, though, really is that this needs to do all of this as a byproduct of care delivery, not an additional activity. It needs to be contemporary documentation of care and decisions, timely access to accurate information, data for analysis of trends, preferences, outcomes, financial reporting and accuracy, potentially. Stores and consumables could be measured and restocked promptly, and consequently releasing this time to care, reducing those interruptions of work system failures, releasing this time to care, the holy grail. So in Canberra, what did we do? We were trying to see if perhaps this potential product was able to achieve this. There was a product, and I'm still being somewhat cagey about the details because we're still maintaining relationships with the healthcare organisation following the particular trial. It's located at patient bedside and central nurses stations, replacing current paper nursing documents, looking at a few of the nursing care processes. The overall product development had been developed over 7 years with clinical and academic nurses and 3-step clinical trials through Deakin University, with this point of care focus on delivering documentation and decision assisting. At Canberra Health, there was multi-level stakeholder engagement, development with bedside clinicians, comprehensive ongoing training. They used champions on the wards that they had worked closely to develop the product that suited their needs, and they were providing 24-hour support, and it was on site. And just to, I guess, with the proviso that I was employed to do the research evaluation, not to do the implementation. So I wasn't involved in those things, but they were the characteristics of that implementation. So in doing the research, we were doing a mixed methods evaluation. We had some Commonwealth funding for startup company support, so Innovations Connections Fund. We were using a quasi-experimental pre-test and post-test design, using an ethnographic conceptual framework because we wanted to be in there on the wards, seeing how it was interacting with the clinicians. So quantitative data, we were looking at how far nurses were walking, doing time and motion observations, so actually every minute documenting what the nurse was doing to get a sense of what was the change in their clinical practice, and doing questions and using some hospital data, as well as the qualitative data in terms of focus groups and hallway interviews, where we tried to not have them spend too long. A lot of the clinicians don't have a spare half hour to sit down and have a focus group with us, but they can tell us things as they're walking, and we were collecting that ethnographically to try and capture as much information as we could, and that included wardsmen and ward clerks and doctors and allied health, as well as the nurses who were primarily using the product. It was a 26-bed ward that it was being trialled on. There was a bedside unit at all beds with this multi-directional touchscreen, and 11 of the commonly used nursing documentation tools trialled. So this particular ward had identified they had 55 charts that they tended to use, and they were just trialling 11 of them. So our key data demographics, and you probably can't see that very well at all. We had a number of consents from patients and nurses. We obviously had a lot more in the pre-implementation phase and less in the post-implementation phase, and I'll go into some of that detail shortly. We have the surveys there, part of those about the missed care rationing that nurses were conducting, as well as obviously the focus groups where we were only conducting those in the post-implementation period. So for example, the nurses' surveys for pre-implementation of the nurse care rationing was 27, and we only had 10 of those in the post-implementation. So I'll briefly be covering some of these findings. We really categorise those into 5 areas of influence, looking at software, hardware, environment, implementation, and evaluation. You can see here, so the pre-implementation's in the blue and the pinky colour is the post-implementation. So for example, and we'll come back to some of this data, multitasking minutes, and I reported previously it was about 30% for nurses multitasking. We found on average on this ward that they were multitasking about 50% of the time, and in the post-implementation this moved up to 68%. That's partly because we had bedside documentation tools so that the nurse was talking to the patient while documenting, so that's a multitasking activity. They were also interrupted, and we did wonder whether they would be interrupted less by having these bedside things, because they would then at least be interrupted less by the clinicians, where they'd always be interrupted while they're out in the hallway or at the nurse's desk, but they were interrupted, of course, then by the patients because they were at the bedside. And interestingly, I was going to show you this one, and I picked this one up just this morning when it was mentioned that there's a now journal club for this particular conference, and Professor Enrico Carrera makes this comment that current generation clinical IT systems are designed with the implicit assumption that clinicians are carrying out a single task and their attention is devoted entirely to that task. But reality check is that that's not how clinicians work. And so we've got the multitasking as one component and the interruptions, and you can see what we're showing in terms of our current data. Some of the other aspects, of course, is about, we're talking about releasing this time to care. So you'd be interested to see that for direct patient care, we haven't made a big difference with this particular product, but you might also be interested to see that nurses are actually only spending about 30% of their time at the bedside providing direct patient care, and that is usually of concern to most areas. Some of the products that are being examined, and this is a particular one in mental health, which is why they call them service users, is that direct care is just 26% and other activities are 74%. Many of those activities are necessary. They're indirect patient care. They're communicating with other health professionals, their family members, chasing up service provision, chasing up those blood test results to make sure that's happening. However, there are concerns about the professional delivery of care if we are not actually with the patients. So this has been a big focus of a number of different implementations, really using this phrasing, releasing time to care. Part of it's been about the productive ward, which they've evaluated in numerous frameworks, but really focusing on clinicians at the ground level, reorganising their workflows in a way that can release time to care, potentially. The findings from the Canberra experience was that there was an association of decreased missed care, both reported by the patients and reported by the nurses. However, this was non-significant, and having flagged those sample sizes that I had to you previously, I'm not confident to make strong claims. Usually I'll be trying to highlight this, but I'll explain shortly why I wouldn't make some strong claims about these particular findings. And that is that when we went to the qualitative data, and thank goodness we included both qualitative and quantitative data, so that while there was the usual themes about what was good about the chart and perhaps what we could do differently, there was design fragmentation where the process of implementation created a product that was disruptive to clinical practice. There was an issue of pain and injury in nurses to do with the ergonomic design combined with the chosen workflow design, and unforeseen management decisions where 30% of the beds were closed by the hospital on this particular ward and removing 6 of the 8 trained technology super user nurses, which, as you can imagine, changed the demographics of what we were trying to evaluate quite significantly. I often pull out this slide and use it either for designing hospital design for people with dementia, if you like. You can also use it for software design. It also goes for research experiences about trying to run any kind of product, any kind of evaluation. So our extraneous variables, which we measured, showed that the mean length of stay for patients during this time halved. The number of admitting doctors increased because, of course, after they closed 30% of those beds for Christmas time, they then reopened them but were non-specific specialty. They were overflow beds. So managing to meet the NEAT targets for the emergency department, which meant that the ward just got each and every kind of patient from every kind of specialty, which again significantly changed the demographics of the patients that we were looking after. So they had an increased number of the admissions as well as increased the number of urgent admissions, because this was primarily a chronic illness style of ward previously until it changed. And so in examining, and I've just got a couple of examples to really kind of case analyse what the take-home messages are from here. One of them was about this nurse injury, which came up as one of the themes in the qualitative data. So there were a few problems with the hardware in that it didn't have elbow support. It's funny, I've got this book, I've had it for years for doing my PhD, but you can see that she's doing this touch screen up here. It wasn't quite that bad, but it was up here. And that worked okay when you were just entering in a couple of things, but if you had to do a 20-minute patient admission, then that was problematic. And so the combination of the software with the hardware was what the problem was, but really it was the decisions about what the software was being used for a 20-minute patient admission that became the problem. And this implementation process, it was left to CNC of the individual ward to decide to make these design decisions, and they wanted it exactly like paper. They wanted no automative functions. They were reluctant clinical contributors working on top of their normal duties. They weren't given any supernumerary support. There was a top-down driving of the implementation. They were told this was a directive from the minister, and they were just trying to do what they were told, and that was a creative environment to come up with a system that would suit their needs. There was a status quo is safest kind of design culture, that none of these individuals were in a position to be able to take risks, to make decisions that might challenge current pathways already embedded in the hospital system. Another example is rounding. Just hands up if you know what patient rounding is. So I'll explain it to others who are not quite sure. So this is where, and an old school matron would tell you that that was nonsense. That's what nurses do. This is where we have started to bureaucratise nurses checking on their patients, so that every hour they're meant to go around and check on their patients and make sure there's nothing that they require. And there's often a tick sheet associated with it, because that's how we make nurses do what we want. When we were asking these nurses in these focus groups about what are something that we could do to save time so they could spend more time with patients, they said do away with hourly roundings, because what this is doing is making them go around and check on patients, but they still can't actually meet the patient's needs. Because if the patient wants anything, then that takes up some of their time in that hour that they're meant to be going around and checking on their other patients, and actually they've got a whole bunch of activities that they're trying to complete. And what happened with this particular digital product was that the hourly roundings were still being done, even though the computer knew that the nurse had been by the bedside, because she'd been entering in data to say that she was at the bedside. So these could have been alleviated if automation of rounding was done by the computer when nurses were entering data in that patient room. So a couple of simple but rather kind of horrid and messy examples. When we made the recommendations both to the organisation who developed the product and delivered the product, as well as to the health organisation, we've got shared responsibility to vendor and health organisation and vendor responsibilities, and then we've got the combination of them, that customer responsibility about reviewing their governance and policy related to nursing documentation practices, and providing employees who can communicate and understand and really have the autonomy to make decisions about clinical nursing. So if we want system implementation, we need good data. Everybody here loves good data. But if we want good data, we need to understand clinician workflow, we need clinical workflow, and the combination and conflict between governance and clinical workflow to be analysed and understood. E-health is going to highlight what are currently invisible problems. Areas of omission become areas of commission, and this is coming up as well about how fluid balance charts are maintained. At the moment, nurses can make things up, you can dot things down, you can circle things in, you can put in inaccurate information and say this is inaccurate. You put that into a digital format, you need a different button that says, I'm guessing that was 300 mils of urine on the floor. Don't know, but that's a good guess. That's still useful information. We need a way of capturing that. And implicit rationing of care can hopefully be documented as explicit, but we need to acknowledge that it's happening. That's something I'm going to have to race through a little bit. And so this is this example that I highlighted previously about this is an untapped area for efficiency investigation. Those three examples about what we don't know about the patient, they are contested, they are constantly changing, and they're politically charged. Saying that nurses don't have time to provide all the care that they are meant to is very uncomfortable to say as nurses. It's uncomfortable to say to patients, and hospitals really don't want to know about it right now either. We have to find a way to manage this. I was having a quick look at the current evidence. This is a review of reviews looking at how to implement e-health factors. And these are the kinds of considerations that you can assess your product and your implementation strategy against. And I would say in this particular process that these were generally attended to. And the primary challenges were about that inner setting and about that workflow fit. And this is one of the things that comes up. And the complaints about the systems as to whether they are fitting the workflow of clinical delivery and healthcare delivery. But I really think that we're missing this gap about what is a clinical governance fit. And I think that that's not really in a lot of our e-health guiding models. We're assuming that clinicians work with the hospital, but there's often this conflict, and e-health ends up being in the middle of that conflict. This is one of my favourite examples, because this is what's happening as well, is that every time we bring in a new machine, it's doing its own kind of data collection, but it's not feeding into the same e-health record. So nurses are now walking legs to transmit information between two different computers. And so they're still writing stuff on their hands, because in order to get it from there to that, from that computer to that computer, it might be your IV pole, it might be your blood pressure machine, and then now it's our digital chart as well. And it ends up still being written on their hands. So we're not really improving the contemporaneous data collection. There's a lot of comments in the literature about clinical governance, and the recent Francis report in the UK, the Garling report here in New South Wales, focused on over-reliance on documentation as a solution to the many complex challenges facing healthcare and service provision. There's a tendency to move towards auditing and checklists, and that's logical in a managerial sense. However, these tend to provide illusions of assurance and can be a form of documentation hysteria and described as the regulatory beast that must be fed. And they're also setting up the scene for risk as a negative and to be avoided, whereas often risk is part of making that choice. You guys are talking about genomics. Great, we've got all that access to information, but do we want it, and do we know what the consequences and what the prognostic implications are of that information? And that takes a discussion, and it takes shared understanding, and communication isn't just the delivery of information to somebody else, it's coming to a shared understanding. So we're moving forward in terms of examining data as a byproduct of care, because otherwise we're just talking about digital polypharmacy, and we need to get skilled in pharmacology. And the people in this room and at this conference are the ones who have got some of the insight into what are the conflicts happening at this level and how we could better organise the data and make decisions about perhaps what is essential and non-essential documentation. And many people who run hospitals cannot imagine there could be such a thing as non-essential documentation, but it's rationed all the time. We need to actually actively decide what we do and don't want to collect, or can and can't collect. These interactions between people rather than computers are not just nice to have, they're really expensive if we don't have them. Some of my research was looking at just at 4 really common complications, and they're costing 4 times what the superbugs are costing in hospitals. They're associated with communication, mobilisation, hydration, nutrition, hygiene and skincare, basic nursing care, but that's getting rationed. These aren't nice to have just talking to people. This actually can save the healthcare system money and maybe a few people from suffering as well. But we have current dominating factors about new public management. We've got market-based business units where nurses are trying to run them according to a budget, economic rationalism which relies on being able to count the costs. And this is, I guess, my expression in this previous one is that we need to reconceptualise how we're counting those costs. The data is there, but we need to interpret what is there as to what the costs are. And framing what it is that we are aiming for. The disease model of health has been driving a lot of the kind of data that we collect, but we actually want more than just the absence of disease. So how do we use some of those indicators that we already have to choose and pitch the directions of our care delivery? And so activity-based funding has been part of this process, but I was at the conference last year, it's running at the same time now actually down in Sydney. And there really was this discussion that it's not efficient, you want efficient use of money, but it's not efficient if you don't know what quality you've actually paid for. There's a whole bunch of new ways of classifying nursing systems, and I'm sure some of you might be aware of some of them, but I'm not sure how well embedded they actually are. We have a grey tsunami coming our way. I never use this language, I don't like it at all. However, I'm trying to motivate and encourage and incite some of you to get onto this bandwagon as well, because this is an opportunity. There's data out there, let's use it, let's use those brilliant minds in the audience. There's lots of older people and there's lots of nurses. Let's find the data to work out how to analyse the interaction. And I'll have to leave it there. If nothing else, we'll at least hopefully have, this is my funny slide for the end, we might at least be able to understand doctors' handwriting, if nothing else, from e-health records. Thank you very much.